So I think that's the first issue. I think it should not be politicized. It shouldn't be involved with central government. It should be independent. It should be run by healthcare workers, former healthcare workers, retired healthcare workers, however you want to do it, who've been on the front line, who've experienced the inefficiencies, who've experienced the bad things, and be run independent away from the government. So then governments can't come in their 4 years and make all these drastic changes, leave a mess, and then another government comes in to pick up the pieces. So run it
almost like the Bank of England in a way, isn't it?
Exactly. They run it independently.
So welcome, Anuj. Great to see you. Thank you very much for coming. I know sometimes if there's like 100 interviews done, it's a little easier to go for, to sign up for a platform like this and to, to agree to come on. But so I really appreciate you being number 5. I don't know whether you've seen any of the content I've done already, but the idea, the format is we're focusing on ideas and concepts about fixing the NHS. Obviously, we want to talk about your background and a little bit about your journey into medicine and your experiences so far. But I really want to dig into the things that frustrate you, the things that excite you, the things that you'd like to change, as well as the things you'd like to stay the same. So,
yeah. Thank you so much for having me on. And yeah, excited to obviously delve into everything that you've mentioned. Yeah, so a bit about my background. I made a decision quite young actually to go into medicine. I think probably when I was about, I want to say about 13 or so. That's probably when I realized that that's what I want to do in the long term. The way my mind works is very much like I get bored very easily. So I was looking into careers that would constantly kind of keep me learning and new avenues, new medications, new treatments, etc. So then, yeah, with medicine, obviously you have to make a decision very early on that you're going to be committing to that career. So by the time I was probably about 15, I think I started my first work experience. So that was with my local GP. Luckily, he was a friend of mine, or a friend of my dad's. So then I was able to get a week's work experience there.
What's your family background? And do you have siblings?
Sure. So yeah, I have an older brother. He's gone down the finance route. So he's an accountant. My dad is an immigrant from India who owns his own business. And my mum's actually a refugee from Uganda.
Wow.
And,
okay.
Yeah. And she used to work for the government in pension services, but she's retired now.
So she was in the time of Idi Amin, is that right?
Yeah, exactly. Yeah.
But from an Indian background,
Yeah.
because I think Uganda does have quite a big Indian population, doesn't it?
Yeah. So she's an Indian with a Gujarati background. But yeah, obviously there was a massive population that lived over in Uganda, and then Idi Amin came in, and a lot of them came to England, and specifically to the Midlands. There's a big population of Gujaratis here.
And you mentioned it's Leicestershire. You're from.
Yes, that's right.
Yeah. So go back to that sort of decision to get into medicine. Was that Asian Indian families can be quite determined that their children will go into a profession, can't they? Were your parents an influence, or was this something that you yourself?
They were never the kind of people who were like, you have to do medicine, do it. But obviously when I mentioned the idea, they were very happy and encouraging of it, in the sense that for them it was like, a good job, good security, it's well paid, all of these kinds of things. So they're like, for their child, it's a great avenue to go down because it's a lot of security. So all the time that they put into my education, they feel like they're kind of getting a reward for it. So they were never at the point like, you have to do medicine, you should do medicine. But as soon as I mentioned the idea, they were very encouraging of it, and they helped me a lot in the process as well.
And how did you find it? And just talk through, okay, so that first GP internship or work experience, from that, what do you remember anything that stuck out from that time, that experience?
Yeah, so I think my GP is quite abstract, the sense his style and the way that he did things. He's very old school GP. So when I went to work experience with him, he was probably in his mid 60s at that point already. So coming towards the end of his NHS career, and just very direct, very to the point, no beating around the bush. But patients were really receptive to it, which was quite nice. Like the way he had a style that maybe some people wouldn't like, but he'd obviously been with his patients for 20, 25 years. So they were really receptive to his style. So I just liked how he'd built a rapport and a relationship with his patients over many years, which was really nice.
Right.
And then, I like the he did a lot of minor procedures in his practice as well. So it was nice how it wasn't just consultations. He actually was doing some procedures as well, like steroid injections. And then some of the nurses were doing coil fittings and things like that. So there was a lot going on in the practice, and it was just a one GP practice as well. But he still managed to diversify a lot, which was nice.
Fantastic. And that sort of continuity of care that and keeping as much local and in the community is really what the ideal is, isn't it? So David Haslam was telling me there are real benefits to having that long relationship, because the GP gets to know you and understand quirks, and like you say, people respond. So that was exciting. So talk me through quickly the sort of career path thereafter. What was your path?
Yeah, sure. So then obviously we had to do the whole A-levels UK CAT to kind of get into medicine from that point. So I went down the route of doing, I think I did chemistry and biology, and then I did Spanish as my third A-level, just to kind of give myself a bit of a differentiation from that point. And then I ended up going to University of Sheffield. So did 3 years at University of Sheffield and took a year out and did a BSc at King's College London. That was in regenerative medicine and innovation technology.
Oh, wow. Okay.
So that was really interesting. And then I went back to Sheffield to complete my medical degree. And then I think in 2021, I started my F1 in Kettering Hospital.
When you were in King's, where were you staying when you were in London?
I was in King's Cross.
Okay.
Yeah. So my friend that I was living with from Sheffield was at Imperial. I was at King's. So we found like a middle ground between where we could both get to each other's universities. So yeah, we decided on King's Cross.
And how did you like London, and how do you like your experience at King's?
I did enjoy London. I think I enjoyed it more then than I do now. I think it's changed a lot since I was there. But no, I had a great time, and London's obviously fun. There's a lot to do. It's very busy. I live in the countryside, so it was a nice change from that side. And then King's was amazing. Like it was such a good institution. The facilities, the people you meet, it's just like it was just a different world compared to Sheffield. Like you just felt that everyone that you met was just doing something amazing, basically.
It's the creme de la creme, isn't it? And the brain power in that place is just remarkable, as many of the universities around the country, not just London, but particularly, King's College is quite incredible.
Yeah, 100%. Yeah.
Very good. So we get to Kettering, and talk about your F1, F2 experiences, sure. And what did you like? What did you dislike? Can you relate to the residents at the moment? Just kind of the whole experience of a young doctor.
Sure.
What was yours?
Yeah, so I think for one, I quite enjoyed my first rotation. I was on respiratory, so it was heavily medical focused, and it was just a great team. Like the consultants were amazing, the registrars were amazing, even the F2s, the core trainees, they were all so nice. And I think it was such a good rotation to start on, because it really just helped me feel comfortable from being a doctor and that side of things. The thing that was obviously a bit more difficult was the on-calls. So one of the brutal things on my first rotation was that you do one of the medical on-calls, which you were covering about 7 to 8 wards as an F1. But on top of that... How
big is the hospital at Kettering?
So it's probably I reckon there's about 16 or 17 wards maybe in total. Okay. So you're covering it's probably about 20 wards. You're covering just under half the hospital, basically, as an F1. And on top of that, you're carrying a cardiac arrest bleep as well. So it was quite a lot in your first rotation as a doctor. There's obviously support available, but the registrar is also covering the arrest calls, also covering the other wards, also covering A&E. So you often found yourself kind of being left and just expected to get on with it. So that was tough. But funnily enough, I know a lot of people don't like that, but I actually felt that was the best learning experience for me, just being thrown in the deep end and then having to just work it out. So as much as it was stressful at the time, and I'm sure I was angry and upset at the time as well, looking back in hindsight, it made me the doctor I am today.
So any particular emergencies and experiences that stand out that you remember that really were baptism of fire?
Yeah, I think there was one night when I think there was about 7 cardiac arrest calls. There was probably about 7 to 8 patients who had like sepsis or septic-like symptoms. And I remember that whole shift, I think I got 11 minutes to sit down, and I had 11 minutes to go to the bathroom, quickly eat something and have a tea. And that was it. And that was just the kind of definition of a busy resident shift where you're like, it's nonstop.
Right.
And then obviously having to drive 45 minutes back to Leicestershire after having pretty much no sleep was difficult.
But again, there's an adrenaline rush as well, even though obviously you're concerned for the patients, you want to be accurate, you don't want to make mistakes. You're being pulled in every direction. It sounds like a scene from a popular television show.
Yeah, I know.
And when you were going through it, you were still living at home at this point?
Yes, that was a real big blessing, I think. I was living at home, so I did have home comforts in terms of food and things like that. So that did make my life a lot easier. The commute was obviously a bit brutal, especially after the longer shifts, but for me, it was a kind of balancing act. I didn't really know anybody in Kettering. All my friends and family were in Leicester. So it just made sense for me. I was like, I'd rather commute and then come back to kind of home comforts.
And then F2, where were you rotating to at that point?
So I did the academic foundation program. So I was part-time in research and part-time clinical. So my research was basically looking at anemia management in chronic kidney disease patients, and clinical I did renal and I did urology as well. So it was good. I actually quite enjoyed F2 because I think the fact that it was part-time probably made it a bit nicer and a bit more manageable. But I think it was mostly the fact that the rotations were really good.
So for people who might watch, explain the difference between full-time versus part-time plus research. Where does that come into the medical?
Sure. So usually the way that it works is that you'll get F1 and F2, you'll have 3 rotations per year, and you do 4 months on each rotation. And that would just be full clinical, full on call, unless you choose to go less than full time. So when you do an academic foundation program in your F2 year, you'll either have 4 months of complete research where you're not clinical at all, or the one that I had was 6 months on 2 rotations with dedicated 2 days a week in research. Right. So there's different ways that they do it. I was on the 6-month one, but a lot of my friends were on the 4-month one where they just got 4 months of pure research and no clinical medicine in those 4 months.
And with your mix and match sort of program, how did the research function happen? Where were you doing that research and how?
So it was with the University of Leicester, and most of the research I'd come in because it'd be obviously involving patient confidential information, which you wouldn't be allowed to bring home. So I'd have to be doing it in the hospital. But the only problem with the way that I did it was quite stop-start. Like you'd feel like you're getting into a bit of a routine and then you're at work the next day back clinical. So I can see the benefit of doing the 4-month one over the integrated one from that side. But then at the same time, you have it over a whole year rather than just a 4-month block. So,
right. And was there anything you came up with, anything that you discovered or found, or an interest that you developed as a result?
So we did find that anemia was basically not being managed that well in chronic kidney disease patients. And I was meant to get involved with rewriting the trust guidelines and all of that. But it just, with the way research worked, it was so difficult to get everything started. So then it was so late into my program by the time that I actually was able to implement anything. So it didn't really go as far as I'd like from that side.
And when you say difficult to get it started, you mean lining up all the participants who you needed to get sign off or get input, or I mean, what was the difficulty? And how would you, if you were designing a system, how would you design it differently?
So I think the first issue I had is that the project that I was initially going to do was through one of the foundation doctors who was in the year above me, and he was basically finishing the academic foundation program. He said, "Why don't you take my project on and kind of carry it through?" So that was the initial plan. But what I found was the team that were doing that were just very busy. The consultants, they were very hard to get hold of. And I kind of spent weeks on weeks just not really getting anywhere. So then I went to my supervisor and was like, "Look, I've been trying to do this project. I'm not feeling like I'm making much progress." And that's when I kind of pivoted into the different project from that side. So that was the difficulty. These consultants are obviously doing clinic, they're doing research, they're doing conferences, they're doing talks, ward work, etc. So they're so busy. So then for them to have dedicated time to actually help you is really difficult as well. So research can be quite frustrating from that side.
Right. And it's difficult, isn't it? I remember on one of your TikToks, you talked about calling up a consultant.
Yeah.
Will you just tell that story? Because it's kind of funny.
Yeah, sure. So this is actually my F1 when I was on surgery. Essentially, we had a patient who was not doing too well from a kidney perspective. We'd had given multiple rounds of fluids, and the surgical doctors asked me to call the kidney doctors. Overnight in the hospital that I work at, the kidney doctors there's no registrar, it's a consultant on call. So this must have been, I want to say close to 1 a.m. maybe. It was early hours of the morning. So I called this consultant just saying, obviously, that this person's kidney function wasn't recovering and needed some advice. And I was really polite. I was like, oh, so sorry to disturb you. I'm one of the F1s, I just wanted to get some advice about X, Y, and Z. And he responds with, I'm not giving you an answer until you say please. And then I just kind of was like, okay, please, may I? Then he goes, I don't understand your question, and then just hangs up the phone. And then I was feeling really bad, like I'd done something wrong, and like, you question yourself. But then my registrar phoned the same consultant about half an hour later, and he got the same response. So I think he was either just in a bad mood, or I don't know. I just think he didn't want to talk to us, or he didn't think it was a relevant referral. But what can you do?
But it brings, I mean, it's kind of a funny anecdote, but it brings under the spotlight the ability to pass on information, the ability to be cordial, the ability to be receptive. The same with your research, right? If that research isn't happening because people are resisting and not giving over time, and the whole system relies on that flow of information.
Yeah.
And if people are going to be awkward, like you just explained, that makes it difficult. I mean, how many times have you experienced things like that? And okay, people are busy. We understand that. But also somebody gave over their time to help that particular person. In a way, it is the real definition of pay it forward, isn't it?
Yeah.
So, yeah, I mean, just kind of reflecting on that before we kind of finish. We'll go back and finish your sort of training and
Sure.
routine, but just an interesting place to pause and have that thought.
Yeah, so I think I've probably had, I would say, a handful of experiences like that in my whole career. I feel I could have had more, but as I've become more senior and more experienced, I've learned how to stand up for myself and give better handover, so those sort of scenarios are less likely to happen. But generally, I find that the majority of doctors are really nice, really consultants as well. They tend to be really nice. And funnily enough, I remember I've gone on to certain jobs and my colleagues have been like, oh, be careful with this consultant. And then I've ended up really getting on with them. So then I'm starting to question myself, that am I going to become one of those consultants? But no, I personally haven't had that many bad experiences. Probably I can count it on one hand.
So if you were to go back to your F1 self, what advice would you give yourself, and by extension, everybody who's just started in their new role over the last few days? What, in terms of that interaction with consultants and doctors and everybody else in the system, nurses, I mean, it's really, really important. And so much of the knowledge is already there. What would be your
I think the important thing is to make sure that you know your patients really well. So I think that's the key thing. If you know everything about your patient, you know how to articulate the things about your patients, and you know to be direct with the questions that you're asking, rather than spending 10, 15 minutes talking through the whole things about the patient. If you're calling a kidney doctor, the kidney doctor wants to know 3 or 4 bits of information that are important to them. If they ask for further information, that's different. But if you just get to the key points and you say exactly what you're asking, why you're asking it, I think they'll give you a lot more respect, because firstly, it shows that you know what you're talking about because you're being direct with the questions and you're asking niche questions within their specialty. So that's the first thing. I think secondly, from a time perspective as well, like I mentioned, you can be so busy. So spending half an hour to an hour on a phone with a consultant isn't always the best use of the time if you only need one line of information from them. So yeah, just being concise, being direct, but obviously knowing everything about your patient in the background. So then if you are questioned on X, Y, and Z, you're not there, scrambling, going through the notes. So you should know your patients really well. I think that's the biggest piece of advice I can give.
And how, again, it's an interesting concept. What's someone's baseline before their admission? It's not always easy to know that. So of course, there's notes, but what's your best way of getting to know a patient?
Yeah, sure. So I think collateral histories are probably the most important thing that you could do from a social aspect. So if you want to know what a patient was like prior to coming into hospital, the best thing usually to do is speak to the next of kin. And that needs to be done earlier on. So I think a lot of times patients will come through all the way, you get them ready for discharge, and then you're like, can they usually walk? Are they usually this mobile? Like, we wait too long to bring that into practice. So I think early on having a discussion with the next of kin is so important, because you gain so much information about their social status, about their mobility, about their usual health, their Medicaid, everything. Like, especially when you've got a next of kin that's really involved with the health as well, it's so helpful.
Right. So that could be, if they're a distance away, get on the phone, ask them questions. Very simple.
Exactly. Yeah.
Okay, let's go back to the the continuation of your training. So you've done your
Sure.
research, and
Yeah.
what next?
So that was when I hit a bit of a, so I think at the end of my F1, I started to have doubts about whether I wanted to do medicine at all. F2, I kind of was floating in between, and then I decided I wanted to take a year out of training just to decide what I wanted to do. And then I feel after my F2, I just slowly started to see the decline of the NHS. I slowly started to see just everything going downhill. And I speak to my consultant colleagues, I speak to my registrar colleagues, and I just feel that I started to really fall out of love with medicine, because I'd be speaking to my senior colleagues who were basically like, oh, I hate this job, don't do it, go to another country. So then I was out of training for a year. I was locuming in Kettering, actually. I had like a long-term post there. That was, again, it was interesting. I learned a lot. I became quite independent with my thinking and learning. And
Anuj, for those who
yeah,
including myself, I'll put my hand up,
sure,
are ignorant of many factors, medical and non-medical.
yeah.
So how's that work? So you a couple of years of training, and then you can go out of training but still act as a locum. What's the sort of regulatory process? How does
Sure.
that work?
Sure. So if you don't apply for training in your F2, when it comes to today, so this is the changeover day, you'd be out of a job technically. So you would not be in full-time employment. However, if you've worked in hospitals previously, you usually would be able to do some sort of locum, or you could even do a long-term trust grade position there if you wanted to do a certain specialty and gain some experience. I wanted the flexibility of locuming, just so I figured out exactly what I was doing. So,
but at that point, you're not a qualified doctor, are you?
You're GMC registered, so you're officially qualified doctor, but you're not a specialist. So
I see.
So you're still technically, I guess the old term is junior doctor,
Right.
but you haven't specialized in anything, but you've completed the foundation training. You've got your official GMC license. So from that
So
side.
how many years are you in at that point with the medical education and those 2 years? What would that be?
So I did 6 years at university and then 2 years, so 8 years.
So you're 8 years in. So in that time, so you were locuming
Yeah.
in Kettering still, or?
Yeah, in Kettering, I was doing kind of a mix of different specialties, acute medicine and general medicine, and kind of floated between the two.
But without the added training. So what is extra in terms of the training that is formalized that you would have been doing had you applied for?
So it would be actual designated months and rotations on certain specialties. So if I was doing internal medical training, I'd be doing, 4 or 6 months on a certain specialty, and then moving on to a different specialty. You'd be on a full on-call rota. You'd have designated teaching. You'd have designated study budgets, leave, all of these kinds of things you kind of give up when you come out of training.
Right. And I mean, for a lot of people, these are real dumb questions, I'm sure. But
no, it's okay.
It is interesting to learn about the life of people who do things that are different to yourself. But that disillusionment, just sort of pick that apart a little bit. And what turns you? Did you turn around? Did you develop a love for it again, or did you? Are you still? I know many people are frustrated about the NHS. I prior to this call, I explained my mother's stroke and passing, and my brother's heart problems, and not in detail, but basically we've, as a family, been incredibly well served by the NHS, and I'm hugely grateful. Yet those experiences also showed me the frustrations that many at the front line were facing, and there were, as a result of those, there were what I'll call blips in the care, where it's almost like taking 3 steps forward and 5 back. It undermines the good that can be done. Not sufficient for me to be super angry, but more curious about how difficult it is for those people in the system, where they feel that the system is pushing against them. They want to have greatest impact and greatest contribution, and yet really silly things get in the way, like the craziness of not being able to find a computer that works. And I mean, there's a list. Maybe we can go through that list, but going back from that time where you took time out of your training, at some point you changed your mind and wanted to continue. So
Yeah, sure. So if I start with maybe the actual training side of things. So in my F3 year, which was the year that I was locoming Kettering, just having conversations with my family and stuff, and they were like, oh, why don't you just secure yourself, do some sort of training, and then you'll come out of that with a security blanket, and then you could obviously go forward from that. So I actually applied to GP training on the deadline. The last day I was on holiday with my family, and I got my laptop and I quickly applied. And the day after, I withdrew my application because I basically just realized that I just don't want to do it, and I was just forcing myself to do it. And I think so for your question, have I fallen back in love with it? The answer is no. I think I've actually probably fallen more out of love with it. And I think that's probably a bit of fault by myself, in the sense that I haven't pushed myself into a training program. So then naturally I'm just slowly losing love for the profession. But I think the second thing is that I've just realized that there's just so much more to life than being a cog in a wheel, basically. I think, yes, starting a business has made me realize that as well. There's just a lot more to life.
So we'll come to that. We'll come to PAX Scrubs, right?
Yeah.
Or are we talking about something else?
No, PAX, yeah.
Okay. So you're saying you didn't specialize, you didn't, so you've continued just essentially doing locum work or okay. And how many years have you done that?
So I've just completed my second year.
Okay. So before we get into the business, let's talk about the things that frustrated you. Because again, from a systems perspective, imagine you're Kier for the day or king for the day, or you're in charge. Yeah. You're the person. What would you do to fix this system? I know it's complicated. I know there are many aspects. Personally, I believe that we need a healthy economy to have a healthy health system. We need to focus on primary care clearly, but we also need to focus on prevention and getting people really to have less stress, which means a healthy economy is required. We need less chronic disease, which means people taking care of themselves. And we need to kind of take away some of the things that make people addicted, sugar and other things. We have to do things on a system level to change these basic morbidities that put too much pressure on the system. But I'm giving those keys for you for the day. So what would you do?
So I think you're completely right. It's not just the healthcare system. I think the whole country and the way that we look at health needs to change. People's understanding of food, doctors included, is not as good as it should be. So the only reason I've come to understand food is because I went through a phase when I was 21, 22, really focused on the gym, counting my calories, how much protein is in thing. So I think the education of food in this country is so poor, and that's even to healthcare workers. We weren't taught about macronutrients that well. We weren't taught about different types of food, different types of vitamins in food, and how important it is. We're always taught about a condition, how to identify a condition and how to fix a condition. And we don't get enough teaching on prevention. Obviously, there's the basic things like exercise, eat healthy, but what does eating healthy actually mean? So that's probably the first thing. Essentially, we need better education for healthy food, for exercise. Like, what does that actually entail? What is healthy food? So I think that's the first thing. I think in terms of the actual NHS itself, it's so difficult because this is years and years of mistakes that have happened. It's not just something that's happened in the past 2-3 years or the past year. This is years of mistakes. So, they've sold off parts of the NHS. They've sold off bits of land. They've sold off services within the NHS to private companies and are now paying more because of the fact they're outsourcing it to private companies. Because
the private finance initiative, I think you're referring to, or probably things similar to it, which was in theory a good idea when, rather than limits on borrowing because of state aid and government rules, they needed to invest in hospitals. And it was a clever way of financing and supposedly putting these things off balance sheet or delivering long-term contracts.
But I think the issue there is that it was a good short-term fix, in the sense it temporarily bridged any cash flow issues. But now we're paying the
exactly.
the negatives for it now. So, for example, with these diagnostic centres they've been building, they sold off bits of land, and now they're paying companies like InHealth and all of these other private companies to go and build a diagnostic centre and run it, which is costing the taxpayer a fortune. Whereas initially, if we'd actually invested into these things with the NHS, yes, temporarily it would have been a big cash loss for the trust.
Right.
But over a longer period of time, you've then got a functioning NHS run system, which is improving diagnostic, which is improving patient outcomes, which is improving cancer waiting times, all of these kinds of things.
But again, you talk about long mistakes that were made in the past, and we're still saddled with them now.
Mm.
But also, it's kind of there's an embedded mentality, isn't there, around procurement and other things. And an example, I was actually talking to one of the health techs from the stroke ward that my mother was in, and she lives fairly local to me, and I see them in the coffee shop. In the Costa we go to locally, and in this ward, in the Royal Stoke, it's Ward 127. It was basically a significant porter cabin that was built, I think maybe just before COVID. I can't quite remember when it was, but it was in like a space where there was some car parking, and it's a funny shaped hospital. And somehow they realized, okay, we can put a couple of wards here, so there's one ward on top of another.
Yeah.
But this prefab, I mean, it's big. It's a huge prefab, but there must be, there's probably easily 10 bays in up and the mirror ward down. I think it's the brain injury ward below. But there's no fresh air. And the ventilation system apparently stopped working, or they turned it off in COVID. So it's either too hot or it's too cold. And they wanted to put windows in, to get some fresh air. And yet the quote for the cost for putting these windows in was just so crazy. Whereas a little double glazing company from down the road could probably do it for 1/10 of the cost. I mean, it's things like this that just the cost of changing light bulbs and silly things. How do we change that and go back to common sense? Having a maintenance crew who are paid fair salary, and literally they get these things done quickly and easily. I mean, it's those kind of things that just drive people crazy.
Yeah, but I think the problem, I've mentioned this, I think, before on one of my TikTok videos, is that the problem is that the NHS is a political thing, essentially. People use it as political leverage. So Labour, for example, when they were coming in, they use resident doctors and nurses and stuff as leverage, being like, we'll work with you guys to improve your pay, to improve your conditions. So then they got a big majority of vote from healthcare workers, which make up a big proportion of the population. There's a lot of healthcare workers in the UK. And then obviously the same way that the Tories are now saying, resident doctors are being greedy, etc. And that's aligning with a certain type of population and a certain group of the population as well. So different political parties use the NHS to basically to leverage their voters. So I think that's the first issue. I think it should not be politicized. It shouldn't be involved with central government. It should be independent. It should be run by healthcare workers, former healthcare workers, retired healthcare workers, however you want to do it, who've been on the front line, who've experienced the inefficiencies, who've experienced the bad things, and be run independent away from the government. So then governments can't come in their 4 years and make all these drastic changes, leave a mess, and then another government comes in to pick up the pieces. So run it
almost like the Bank of England in a way, isn't it?
Exactly. They run it independently. That's the way that we will get on top of actually reducing the inefficiencies and actually looking out for what's best for patients, not what's best for a political party's balance sheet.
Yeah, I mean, what do you think about the abolishing of NHS England as an organisation? I mean,
it's difficult.
We talk about mistakes made. The reforms of 2012, which were a little bit before your time. I guess just as you were starting your training, they were started to be implemented, and that level of change where doctors were all of a sudden now have a part of commissioning groups, and the infrastructure that was already in place is essentially abolished, and people have now got extra GPs who I'm not quite sure how it worked within the secondary care environment, but in primary care, GPs who literally were busy enough have now got to get involved in that extra management layer of commissioning. And now they're used to that. And now that is changing potentially with the reforms that are underway. Is it possible just to have continual evolution in this system? In a way, can be worse than wholesale change. You need sometimes system change that is well designed. But like you say, the politicizing of the process means, although there's a 10-year plan that's come out, the detail in that 10-year plan is fairly obscured. I think is fair to say. I will do a video talking about it, and I need to read it fully, so I haven't read the full document. But yeah, I'm just curious to your thoughts and going back to those, what kind of change do we really need, and how would we put in place that continuity without the politics?
Yeah, I think it's difficult. Obviously, with NHS England being abolished, it's sad. You don't want to see people losing their jobs, redundancies. And I think that's another thing to consider. I know a lot of doctors, me included, being quite vocal that it's probably the right thing. But then looking at the perspective of the people working there, it's never nice that people are losing their jobs and they've been in this organisation for years. And then with it overnight, the government have come in and said, we're going to abolish NHS England. So yeah, obviously my prayers go out to them. I hope they find something going forward.
But do we know how many people will lose their jobs? Because my understanding is essentially government wanted to take direct control rather than essentially having that organizational layer that sat between the health secretary and the civil servants.
So I know some family who are at NHS England. They've been made redundant from that. Yeah, so they've been given notice of redundancies, and it was a process that had been ongoing. That a lot of people in the hospitals had been losing management positions and all of these kinds of things slowly. So I think there slowly has been redundancies happening, whether that's due to a restructure or I don't know the exact details of it. But I think coming out of it, people will definitely be losing their jobs from it. I don't think it's going to be creating more jobs, if that makes any sense. If anything, people are going to be losing. But I think it needed to happen in the sense that whatever NHS England was meant to be, it hasn't delivered. So there has to just be some sort of change. But is 4 years of the government being in power enough time to do that? Because realistically, with the way that the elections are going, we don't even know if Labour are going to be in power in the next election. So it's really hard to say, because I think you're not going to see the outcomes and the benefits of any of this for so many years. And then it's about whether a new party comes in and there's another change. So you'll never know if this was a good idea, because I don't think the government are going to have long enough to see it through. Yeah.
And then will the next government keep or continue the reform? Likely not. Likely they'll use it as a complaint and like you say, leverage to get their own strategy in place, which is likely to be more privatization, isn't it?
Yeah. And I think that's the short-term thing that we were just speaking about. Privatization is a good way to say, oh, we're bringing down waiting lists, we're doing X, Y, and Z. But in the long term, the NHS is like the gem of this country. It's what we're known for. It's what everyone's so proud of. It's what has saved so many lives. It's done so much for so many people. Me and my family included. We've used the NHS in so many different ways. And then to lose that to, a different system is sad, but it's probably the way that it will head in the coming years.
I have a great friend and he continually bangs on about France and Germany being a better system or delivering better outcomes. Now, if you take the American system, obviously, it's not great for the country. There is incredibly great healthcare, but it's expensive. And if you're not wealthy, or then the cost of drugs, there's so many issues with US healthcare. We don't need to get into it. But if you take France and Germany and Scandinavia, there are good parts of that system where if you take some of the inefficiencies of our system, the GP is a gatekeeper for specialist services, for example, needing to provide that referral as opposed to people being able to shop around and go direct and being reimbursed by an insurance system. Do you like elements of that system, or the question of how would you change? That's a different question, because the cost of changing is probably tens of billions. It's expensive to change wholesale a system. So how do you go from one to another. But just on the base, do you actually agree with my friend Phil? Do you think the systems are favourable or?
So I don't know massive amounts about the Scandinavian system. Is it free at the point of use? Is that the case with Scandinavia? I'm not too sure.
I believe so, but I believe there's like well, I'm not sure about Scandi, but in France and Germany, I understand people have to pay for going to a GP. There's a insurance program that is dedicated, as opposed to here we've got national insurance, which includes pensions and it's all a kind of a big amalgam. There it's specific, you paying into an insurance, a health-based insurance program, and you need to pay for different services, but you get reimbursed a portion, 70%, 80% of a procedure. So with the balance coming from your insurance. So I understand people can shop around, they can choose their physicians, they can, in France, for example, there's not massive wards, there are rooms, there are some exceptions, but again, I don't know the detail, and the goal with this platform is ultimately to look at these other systems and ask these questions. But we've got what we've got right now, and changing would be very, very difficult. But I'm interested in, is change possible? And if we take this concept of privatization, every GP is a private contractor. They're a private business. And admittedly, they work to an NHS contract. But like any private business, you have really great ones and you have not so great ones. And a lot of elective surgeries being passed over, hip replacement or cataract or whatever, to private provision, scans, MRIs. I mean, the private sector in health is a big part of the health system, including technology, including suppliers. And if you think of, when I asked this of Sir David Haslam, he said he doesn't care who pays, who does, but he cares who pays. So free at the point of need or delivery is a basic tenet of the NHS. But that sort of commissioning and that provisioning, that's where I think we need an awful lot of work. We need, question is, are the civil servants, and the NHS employees who are buying in whatever it could be, buying in scrubs, or maybe the doctors pay for them themselves, or buying in those windows that I mentioned, or buying in significant contracts. Are they up to the task of, sometimes they're up against salespeople and directors of very large businesses who are paid huge amounts of money and who are very, very clever in how they make sure there's a very fat margin in where really we should be buying very, very efficiently and minimizing the cost at every level, making sure the quality is there. These are the things I think we have to really, really look at. But what are your thoughts on that, on those? And on scrubs, maybe you talk about PAX scrubs as well.
Yeah, sure. 100%. I think what's interesting is that you saw it over COVID, where the contracts that were given out to people, the money that was made from these private companies during COVID, that was probably one of the biggest transfers of wealth you saw over that industry. And a big part of it was that the people that were involved with the government, the people that were involved with local councils, the people that were involved with all these people got really bloated contracts and bloated deals for things to be done. And whether they're up to the task, I think the question is they probably are up to the task, but are they choosing to turn a blind eye to it? Because essentially the stuff that was happening during COVID and the amount of false contracts, bloated contracts that went out, I'm sorry, but if you're in that position, you knew exactly what was going on, but you decided to turn a blind eye to it. And I think that's the key thing. I think you need honest people who are willing to actually make change and wanting to make change rather than wanting to line their pockets, is basically what I think from that side.
I think many people in that position would or did argue that we were so desperate for PPE, we would get it from wherever we could get it. And I struggle to believe it, but that is what people would be saying at that point. I mean, the Michelle Moan thing is just crazy. It really is. It's just the worst example of grift that I think I've seen, other than perhaps Donald Trump. But that's another issue.
Yeah. Well, I think even you saw it with the ventilators with Dyson. I don't know where they've gone. I don't know if they're even used. I don't think they were used. And obviously, I understand we were desperate at that time, and there were probably shortcuts and decisions made to try and speed things up. But I don't know. I just feel that there just wasn't enough thought that went into all of these decisions, and billions of taxpayer money went down the drain. Essentially, we bought all of these ventilators for Dyson, and I don't think they were even used, from my understanding.
It's interesting. At that time, I was very active on a platform called Clubhouse. I don't know if you remember it at the time.
I think it was quite big over COVID, wasn't it? Was that
yeah. And I had a room called fundingtheGlobalGoals.tv, a room. It's kind of like your own radio show, and people could come into the show, or they would be in the audience, and there were some amazing discussions. It was really a fascinating time. But there was one guy who was quite active. He was called Mayor Dowdy, I think, a US, I forget his origin, but he basically had a grassroots effort to make ventilators, and it turns out perfectly good ventilators could be made for not a great deal of money, and they worked and they did save lives. But it needed to be really scaled up, and I don't think it was ever scaled up. But as an alternative to these overpriced contracts, there's always solutions, and often it's really innovation, which goes back to your working kings, and it goes back to that we need private sector, but we need competitive private sector. And the problem that I've identified, part of what I did previously, I mentioned to you before, but it was also working on the economics. And I created an economic theory, which I call the economic food chain theory. And it's really about how in society, capital tends to concentrate into a relatively small number of very large entities, but also speculative finance. And yet what I call the plankton of our economic food chain is those SMEs. And generally, if we can get capital intelligently down to those SMEs and get them, and startups, and do it in a way that includes the ability for failure, but when you do it as a pool, when you do it as a portfolio, frankly, you have more successes, more job creation, more innovation, and yet to get capital for early stage and for startups, the venture model really is very unsuitable for most businesses. It's appropriate for some.
It's very hard, and I think it's something that we've actually struggled with as a business, like the actual availability of grants, funding. And even if you are getting any sort of funding or loan, it requires personal guarantee, all of these kinds of things. Whereas my business partner's in Canada, and he said the amount of schemes there are, funding opportunities, grant opportunities for startups to basically try and grow and innovate is astronomical compared to what it is here.
Yeah, it could be massively, but it's not just, although grant funding and non-dilutive funding is really important, we need to have better ways of creating funds that don't need the kind of return that is expected in venture, but where there's not just money, but help and support. And when you blend all that together, and you can create, and often it's drip fed, funding is drip fed, and it's not efficient. So it's not just about, having more grants available. It's about giving organizations a path to profitability and to their development and scaling, including their export and what have you. And in a way, it's at odds. If you think of your goal, not you specifically, but often if someone's selling into the NHS and see it as a major market, well, the NHS, its goal is to get value to improve a service or make services available to the people who couldn't otherwise have them. That could be a hip operation or whatever, to reduce a waiting list. But it's also to manage the costs. And if you can deliver something at a lower cost at a higher value, then that's great. That's a value add. But if it's more expensive just because of the demand, then that's not so great. And therefore, there's a balance. And if you think of the private sector serving the health system, what we should be doing is pushing the cost down using AI, but still enabling those organizations to be profitable, still enabling them to thrive, to export knowledge and expertise and services and products overseas. But we've just got to do that within a system. So there is that tension of, I know Dr. Grace at Every Doctor, she's dead against privatization at any cost. And I am against privatization when it is compared to, the NHS as it should be. But that who delivers should be who delivers because they're best to deliver that part. And that could be a team within the NHS paid for by the system, or it could be private enterprise. It doesn't really matter to me. What matters is the end customer, which is the government and the population and the patient, not necessarily in that order. They're getting value for money and they're getting what they really need. And what we need is a thriving country. And the health system is part of that.
I think that's the key thing, isn't it? I think the problem is that there's such a mess in the economy. And essentially, I've never seen an economy in the history of the research that I've done tax their way to a prosperous economy. And essentially, we're getting more tax, more burden on people. And anyone who has any sort of innovation, any sort of technology, any sort of small business is leaving. Like, so many of my friends have left who have got businesses, small businesses, startups. They've gone to Dubai, they've gone to America, because there's just better opportunities for them there. I think I saw in the news the other day that Wise, the payment provider, they're moving their listing to the NASDAQ because they're saying that they're going to get better returns, etc. So if some of the biggest companies and the biggest innovators in this country are leaving, where does that leave the rest of us who are just...
Well, I know a guy called Dan Wagner, and many years ago, I had an idea for a business and in the education field, and I managed to get a chairman to agree to participate, and the business never came fully to fruition. But that chairman he was called Michael Mander, and he was also the chairman of something called MAID, M-A-I-D, and it was a database business, ultimately, an information, I think market access information database or something. And eventually it sold to LexisNexis, and the entrepreneur behind it, called Dan Wagner, is very, very colorful. He's a fascinating guy, and he's kept innovating, kept doing things. He's had ups and he's had downs, but he created something called Resolve AI, I think it is, Rezolve, and it's a retail technology using LLMs to improve the retail experience for online retailers. And he recently wrote a post on LinkedIn about the head of the stock exchange saying we need a new Tell Sid campaign. And Tell Sid was a campaign years ago that Centrica, or British Gas, did for selling shares to the to the masses. Post was how ridiculous this comment was from the head of the stock exchange, because we have many problems around the provision of risk capital. And he had to go to the US. He did a SPAC, Special Purpose Acquisition Corporation, which enables people to raise money indirectly or directly on the stock exchange. It's almost a reversal. And he did a SPAC to raise capital for his company in the US. And because the risk aversion here for our institutions is massive, institutional investors are not excited about provision of risk capital. So not only are the returns for Dan and his team and everybody involved essentially going to the US, the returns for the investors are going to the US. So we've got a double whammy. And those returns really should be here for European pensions and pension funds and UK pension funds. This is a massive problem. So when you talked about grants, yes, grants are an important part, but what we really need to do is to innovate with our capital markets. And 100%. We need to, and there's many things that can be done, but it's expensive, and there's a lot of lobbying and a lot of work to be done to get these pension funds to change. I mean, a number of years ago, the actuaries did come together, and they enabled pension funds and life insurance and other institutional investors to invest into venture capital as an asset class. So that was a change that did occur, I think probably 20, 30 years ago now. But we need to do that and democratize capital so that not only if you're an app developer and a super fast business that can go from zero to being a unicorn in 10 minutes, we need to invest in everything else, including analog businesses that are enabled by digital. And that's really, really important. And we need to create an economy that works. And this concept of more taxes, I agree, more taxes don't necessarily work. And there is this perception, particularly by Gary Stevenson. Amazingly, I bumped into him just a couple of weeks ago in the Yurt Cafe in Limehouse. So hi, Gary, if you're watching. Probably not, but Daniel Priestley is saying don't tax the rich. There was a fantastic debate on
Stephen Bartlett's, wasn't it?
Stephen Bartlett, exactly. And I think over 4 million people have watched it now. But the arguments are pretty crude. Essentially, Daniel Priestley is saying, don't tax more. It's pushing people away and the rich are mobile. Gary Stevenson is saying, tax the rich, tax the rich. And for me, it's not actually about the taxes. It's about the productive capital.
Yeah.
So if that productive capital, rather than being in institutional investment or in illiquid or very liquid forms of investment, which isn't delivering productive value into an economy. Rather than that, if it's going into the real and the really intelligent economy, and what you could do, what I believe government should do, is take a portion of those, rather than overly tax people, say, okay, you can have non-dom status or the equivalent and lower taxes, as long as a portion of your investment is invested or of your capital is invested into these types of funds. And when you blend capital together and that capital goes to the early stage, essentially it means the returns can be greater. The risks are there, and the risks are there will be failure. But if you do it in a certain way with value adders alongside the investment, and invest from early, mid to late stage all in one fund, and the funds have got to be big enough, then it enables much greater job creation, much greater innovation, overall returns. And although there's failures, those failures aren't on the whole portfolio. They're only on a small portion of it.
Yeah.
So
exactly.
that whole concept of tax, we need to create a lot more tax creators, and we need to tax them fairly, but penalizing them means they will go away. So if we can incentivize them by saying, okay, you've got to hold these shares, and it is a little bit like EIS or SEIS, the Enterprise Investment Scheme, where you can raise money and there are tax incentives for both investors and for those who are essentially raising the capital. But those schemes are woefully inadequate. They need to be ramped up by a factor of 30 and be a lot better designed. But just coming back to PAX Scrubs, just tell us the story of PAX Scrubs, because it's fascinating. I like your social media. It's really good. How did you get involved? What's the background of your co-founders, etc.?
Yeah, sure. So Moyes and Frankie are my two business partners. Moyes was the year above me and Frankie. Frankie's in my year. And essentially, Moyes and Frankie lived together at university. And they went to university in Leicester. So they did their F1 year and F2 year in Leicester. So obviously I met them in my F1 year, and they were initially talking about starting this Scrubs company. And me and Frankie were quite good friends. We used to talk a lot in the mess and just on breaks and things like that. And he'd ask me a lot of questions, and I'd just say things. I'd be like, oh, why don't we do this? Why don't you do this? Why don't you do that? And then I think the more we spoke, he was like, oh, I think maybe I'd add some value to the business. And then eventually they'd already started doing a lot of the groundwork, and they said, why don't you join? So then, I decided to join them, and essentially, the rest is history. And we've just been on a fun journey so far. I think it's been probably another reason why I've not pushed myself into medicine, because I'm really liking the way that the business is going, and I'm liking the vision that we're seeing with the business. And it's also meant that I've been able to commit a lot of time to it as well, and being able to really focus on trying to, scale that business and actually come up with plans, marketing plans, growth plans, all of these kinds of things. So it's fun and it's interesting, but I think I'm facing a lot of the difficulties that a lot of business owners are facing in the UK, where it is tough. The UK consumer is struggling right now. You're seeing it in retail. A lot of shops and things are closing down. So naturally you're seeing that in the business as well. It's very seasonal. So people, don't spend a lot of money in the first half of the year. Then you start to see it pick up in the second half of the year.
Who's the customer?
So customer tends to be healthcare workers. So it'd mostly be doctors of all grades. So from medical students all the way up to consultants. We supply some private clinics or mini private hospitals. We've done dentists, dental practices, vets, nurses, pharmacists. So a plethora of healthcare workers in different types of clinics is basically who we currently supply. But it's just interesting just to see kind of, that's describe it, but essentially seeing how owning a business opens your eyes up to so many more things, in the sense that just when you're in healthcare, you're very much in a bubble. You live in a bubble. You do healthcare. You don't see anything really outside of that. From university to now, you just live in this kind of one-way path, which is like, I'm going to go to university, go into training, go and do this. But you actually start to gain a better understanding of so many different things when you own a business, like consumer psychology, marketing, all of these kinds of things I had no idea about. If you ask me, oh, how do you market a product? I'd literally be like to you, I have absolutely no idea. But now I'm starting to understand customers. I'm starting to understand the psychology of customers. I'm starting to understand sales. I'm starting to understand technology better, AI, as you've mentioned. So all of those skills in the space of being in a business for 1.5 years, that I'm not saying I'm amazing at it, but I've just developed basic and core skills.
Have you watched some Gary V?
Who's that?
Gary Vaynerchuk. Have you not heard of him?
No, I haven't.
Okay, I'll send you some links.
Brilliant.
So he's like he had his father, I think, had a wine business, and he turned this business into like a huge thing. But he then, for his father, and he's just one of the most visionary marketeers. He's now worth mega bucks. He's quite vocal. He can swear a lot on his content, but he's, like the doctor you mentioned, was your GP, is brutally honest.
Yeah.
Well, he's a bit like that, but
okay,
you've got to see him, Gary V.
No, well, I'll check him out 100%. I'm always looking for like new people to listen to and stuff, so that'll be great.
Yeah, but it sounds like you're doing great. So, but what is the vision for the business in terms of where do you buy the product? Where do you manufacture? What's the what would be your ideal contract? Is it selling to individuals? Is it selling to private hospitals? Is it selling? Who's buying?
Yeah, sure. So I think from the first side of things, the manufacturing side. So we currently get it manufactured in China. We initially looked at getting it manufactured in the UK because we thought that would be kind of a good USP. But getting it manufactured in the UK, firstly, the garment industry is dying here massively.
And you live in Leicester.
Exactly. So that I had quite good friends who are in the garment industry, and they literally said to me, like, it is absolutely dying in this city. It's dying in the UK. Most people are moving out to Morocco, Vietnam, China, India, Pakistan. They're the kind of 5 places where people are focusing their manufacturing efforts. So they basically said that even if you find a supplier here, there's a chance in a couple of years that they may not be around. So don't take that risk. And they said to just stick to doing it predominantly in Far East Asia. So we currently have a manufacturer in China, but we're also planning to discuss with one in Pakistan and Vietnam, because what we've essentially learned is that we don't want to rely on one supplier. That's a mistake that we made in our first year, and we got screwed a couple of times with it. So we're basically manufacturing in a few different factories, so Pakistan, Vietnam, and China. And then who are we selling to? So with our marketing is probably more geared towards junior doctors, so resident doctors. I feel that we've kind of cut through the noise of scrubs companies and done our marketing a bit abstract and a bit different. We're vocal, as I've shown on my TikTok. We're happy to talk about issues. We're happy to stand up for doctors. We're happy to do all of these things. And in the process of doing that, I feel that a lot of people find us quite relatable.
Right. And the interviews as well. You go and a couple of you rock up, and it's great. I really like the marketing. It's good.
Yeah. So but that's probably the bulk of our customers is probably resident doctors. But obviously, there's 2 sides to the business. We have retail and we have B2B, which is obviously the business side. So that's more towards dental clinics, private clinics, and a couple of private hospitals, which we've done as well. That's a bit of a tougher market to crack, but it's something that we're kind of working on at the minute. So we've kind of got our focuses on 2 channels, and that's the UK side of the business. And the longer term plan is that we want to scale in North America. So my business partner Moyes lives in Canada. So we're planning to be supplying his residency program there with scrubs, and then basically improve our presence in North America. And then I think that's where the bigger market is in the long term.
How long do they last?
So these that I'm wearing now, I've had since F2, so beginning of F3. So this is about 1.5 years, 2 years, and they're still in good condition.
Fantastic. And is this something you think is going to be big enough for you to quit your doctor role and focus 100% on that? Or
so I think the only issue that I'm finding with the business is about how capital intensive it is, because it's a product based business. It requires a lot of cash up front. It requires a lot of cash being tied up. So from a cash flow side of things, that's always been our biggest struggle. So I think the issue that we're going to face with scaling is going to be finding enough capital to deploy to allow us to scale. So I see it having a great future. I think we've created a really good brand. I think we've got a good product. I think that's the main thing. Our product is really good. So a good marketing, a good brand, a good product. But essentially the biggest issue is going to be about how do we fund this scaling? Because if we truly want to scale into North America, that's not going to be done off my locum salary and Frankie's PhD salary and Moise's residency salary. That's going to be done off external investment, basically. So that will be the key. And I think we'll hit a point where I think, we'll be plodding along like we have. We have been growing our revenues. Everything is trajectory wise pointing up. But I know that we're going to hit a point where it's going to kind of get to here, and then we're either going to need to go here or we're going to have to go here. And I think that's going to come soon. And that's basically where we're discussing about how we want to raise capital to actually truly scale in North America.
And, US is a massive market, a massive healthcare market, obviously. But what's the competition out there? What is the...
Sure. So it's a competitive industry. I think you're seeing a lot more pop up now. So I'd say UK-based scrubs companies, there was probably, when we started, maybe a handful of decently sized ones. And then you obviously have the US ones, which are billions of dollars worth of companies. But now you're seeing a lot of smaller ones crop up. But again, I think what I'm seeing is that a lot of people are doing it kind of as a side hustle. I'm not seeing anyone go all in, guns blazing on it like we have. I think a lot of people are kind of doing it while working and then, seeing how it goes and all that kind of things. Whereas I feel we've actually kind of gone a bit gung ho in the sense that, like, if you can see on our social media, like we've grown exponentially over the past year, despite being, only around for half the time of a lot of companies. So yeah, that's what I'm finding. It is a competitive industry. It is a competitive market, but I'm not seeing anyone really stand out yet from our side.
If I had anything to say is, number one, really understand the competitive landscape. Use ChatGPT. It amazes me how good it is.
Yeah.
Really try and map who's out there, look at their marketing, look at where they're purchasing from. I'm not saying you got to copy every element, but just take or of one. But if you look at the landscape, you then can differentiate as you've already doing. I mean, so
that's what we did. That was the first market research we did. We went through all of the scrubs brands out there and we said, if we put all of their pages next to each other, they all look exactly the same. So we were like, we're going to come and do something different. And I think that's what we try to do.
Right. But you can do that with other aspects of the business.
Yeah.
And going back to that, funding your cash flow or the cash flow requirements to fund the growth, really the best thing is to find people who've done it before and get them on board. And if you can find people who've done it, not necessarily with scrubs, but with other garment and textile brands, then if you've got a market size that's big enough, if your marketing is already succeeding, then if you can get an angel investor who knows, I'm not suggesting you go on to Dragon's Den, but the kind of Tuka Solomon, he knows this industry, and that knowledge can be invaluable.
I think that's
but I think it's great what you're doing. I can see the potential. I'm sorry that if you succeed, you might not be a doctor within the NHS, but you clearly care for the NHS, even though you're frustrated by it.
I think that's the vision as well. I think in a bigger term picture, we wouldn't just be making millions of pounds and then just flying off to the Caymans. It would be a case of we'd want to use that to try and give back to healthcare workers in whatever way we can, whether that's we already do offer, we offer a lot of value to our customers, a lot of even my personal page, a big reason that I did it was to just help resident doctors and obviously give them a bit of insight into what being a resident doctor is like. So the bigger picture is to basically put that back into helping resident doctors, whether that's with mental health, whether that's with career choices, anything, just basically offering value back to our customers, basically.
And by doing that, you are helping the system, whether it's, and I use the name Let's Fix the NHS almost tongue in cheek, because I believe you fix the NHS by reducing the burden on it, by tackling all the issues like discharge and how many beds are taken up by people who don't need to be there but can't have care because it's not available already. There's so many issues about this system where if we can tweak and change and reduce that burden, including by the health of a nation and public health activity and campaigns. And in Manchester, they've got a program called Live Well, all about getting community health services integrated and embedded so people taking more responsibility and supported locally. All of these things are critically important. Ultimately, you want a healthy and thriving nation for people to have great lives, long lives, healthy lives, and have, something that they can be proud of. And I see the world going in different directions, unfortunately. And I think you can't lie down and just take it. You've got to create, I think it's important to create a positive narrative that people can buy into, and because it's genuine and it's intelligent and it makes sense. And it comes to me where we need to fund that intelligent economy, reduce people's and improve how these organizations work. And the alternative isn't pretty. So before we close, do you like that vision? Is that something that you think makes sense? I mean, I like yours for sure. I think
100%. No, I think obviously everything you said is really interesting because I agree with so much of it. I feel a lot of your points are quite, I'd say like similar to Daniel Priestley, kind of in the sense that like you're all about innovation, developing business economies and creating more jobs. And I think you talk very similar to him, which is nice because I'm a big fan of him as well. So no, I think everything you've said is true. And I think essentially, as much as we're like the NHS is just one part of it, and I think that's the key thing, isn't it? And there's so much more that needs fixing, and I think that will come with time. And I think people like you who are focusing on aspects of it is what we need. We need more people like you. We need people standing up to the issues, actually raising awareness about the issues, and doing more to basically try and help people. It's honestly like admirable what you're doing, and I'll support you all the way.
Anuj, that's really, really kind. I mean, Daniel Priestley, that's a compliment. I think he's great. I think I also do like Gary Stevenson, even though I don't fully buy into his solution.
Mm-hmm.
I think, both of them, if we go back to that debate with Stephen Bartlett, I think both of them are right and both of them are wrong at the same time.
Yeah.
And my point being is they're missing the irresponsibility of institutional investment and how it is concentrated and how that is, the bulk of capital in society is managed by pension funds and life assurance organizations and other institutions. And yes, sovereign wealth funds and high net worth. But when you really look at where the real money is, the money is owned by the people, and yet they're beneficiaries. It's managed by those heads of pension funds and the people who advise them. And the problem is that capital isn't delivering what I call PVA, productive value added. Many years ago, there was a consultancy in New York called Stern & Co. or Stern Stewart & Co. And they came up with this concept called EVA, economic value added. And that was one of the sort of things that created the sort of private equity type structure, where if you put a lot of debt onto an acquisition and only use a little bit of equity, then your economic value that you add can be greatly enhanced because the equity that you're using for that acquisition, if most of it is debt, then, but if you can even put less equity and even more debt. And what happened is, and actually that's many of our healthcare companies, Southern Cross and others, they were saddled with so much debt, their business models became unviable. The private equity companies that actually made these acquisitions and sold to one another, they made lots of money and they extracted that money, but the businesses that were left were saddled with that huge debt, a little bit like private finance initiative activity that we said. So that EVA for the investors could be okay, but for society, it was very, very bad. And what I believe we need is PVA, productive value added. So are we creating positive externalities, which is a negative externalities, a hidden cost that it could be pollution or it could be, things that others are left to pay for. Whereas a positive externality is something that's good in addition to the things that we can typically account for. And if we can do that, the reality is that money that's going into the system, that is going into mega corporations and going into speculative finance, it's not delivering productive value into the real economy.
No.
So it really everything starts with you can only tax so much, and taxing too much is bad, but taxing too little is bad too.
Yeah.
You know, if you are recognizing what you need is to use that capital most efficiently to create the jobs. 60 to 80% of all jobs come from SMEs. Major corporations, actually, their job is to get rid of jobs, and AI is going to make that much, much worse.
Yeah.
So, you know, if they can be profitable with less employees, that's their objective.
Mm-hmm.
But the reality is those small, you know, what you're doing and your colleagues, you are the future. You are what is the plankton of that food chain, that economic food chain. And yet we need to get more sophisticated ways of getting capital. You and me, I've struggled so many times in my life and trying to raise money. And I decided, actually, you know what? I'm going to figure out why this is the case and do something about it. So the fact that you liken me to one of them, that's very, very kind. I appreciate. But what we want to do is create something that will make it better for everyone. And I recognize, just as you did using social media, this is an important way of getting that message out, and fixing the NHS is one thing, but there's lots that we need to fix. So the vision for the platform is a bit broader, and ultimately it's scalable. If you think of these issues, they're universal. The doctors in France, they probably have got the same frustrations as the doctors here, the same in Uganda,
100%.
the same in the US. Forget that the people who have that knowledge and the ideas, often they are ignored. And if we can find a better way of incentivizing that knowledge and proposals and ideas to come to the top and get traction and be implemented, then we can turn the tide, I believe. Anuj, just finishing off, just your handle, and are you on Instagram as well? And what other platforms are you?
Yeah, so I'm mostly just on TikTok. I do have an Instagram, but my TikTok's just Dr. Anuj Thakkar. And then, drop me a follow if you want to hear me ramble about residency and being a junior doctor.
No, it's great. And your style, how you do it, just kind of, how do you prepare? Do you just have a thought and think, right, I'll TikTok that? Or what? Do you have any sort of system, any process?
No, so you could probably tell in my videos that I'm very because I do it all on the spot. So if I have a thought, I'll just go upstairs and walk around and video the film. I don't plan anything. None of it's planned content, really. It's kind of just something that's annoyed me at work that day, or something that's I picked up on that's annoyed me, or something that came to my mind that annoyed me. I'll be like, okay, let me just talk about it and see what people think about it. So that's basically the style.
Very good. Well, it's very effective, I can tell you. Now,
Thank you,
so we will, we're going to do panel discussions at some point.
Sure.
For Let's Fix the NHS. And the goal ultimately is to do kind of mini question time type events in different areas. So I'd love you to be part of the community as we're growing it. And of course, I'd love to keep you in touch.
Of course,
with how
I'd be
this
more than happy
develops.
to.
So Anuj, thank you very, very much. This has been very interesting. We want to get a health system that thrives with all parts of it, whether it's NHS or non-NHS. And I can see you and your colleagues will have a big part of that. So thank you again.
Thank you for having me on, Steve. Appreciate it. And well done for all you're doing as well.
Much appreciated. Thank you.